All right. Hey everyone, thanks again for joining today. My name is Simran and I'm with Canopy. Canopy is a co-working space based in San Francisco. I'll put a link to I'll put a link to our website in the chat box. Today we're joined by Fuse Project, and they're going to be talking about their process of transforming design with strategic thinking. At the end, we're going to open up to Q&A. Hopefully some more people are going to come in. I see some more people are coming in now. So we'll open up a Q&A at the very end, so you can digitally raise your hand or you can just pop it in the chat box and I will get the questions over to the speakers. So first off is MC. Go ahead and introduce yourself.
Yep. Hi, thank you, Simran, for having us today. My name is MC. I'm a senior innovation strategist with Fuse Project. And for the project that we're going to be talking about today, I was in the role of lead strategist, which meant really partnering with design to identify the problems we were trying to solve, identify those design opportunities, and working with the team to get to the finish line.
Hi, I'm Judy. I am an industrial design at Fuse Project. For this project, I particularly was more focused on the kind of physical aspects of the design and kind of more about the user experience, and also thinking about manufacturing and other kind of more of the mechanical side of the project.
I am Naomi. I'm an interaction designer at Fuse Project. I focus on UI for the ventilator and help the research with the team.
And I'm Harriet. I'm the communications manager at Fuse Project. I'm excited to be here again with Canopy doing another talk as part of this series. So thank you, Simran, for having us. For those of you who are just joining us now, I'm Harriet and we're on the line here with MC, our senior strategist, Judy, our industrial designer, and Naomi, our UX designer. And we all work together at Fuse Project. So today we're really excited to talk a little bit about the research and strategy that went into a ventilator project we've been working on with Massachusetts General Hospital. We've actually been engaged on this project since the beginning of lockdown. So the entire effort has been about virtual collaboration and figuring out new ways of working together without physically, having our hands on a product to tinker with, but also not ever being in the same room with each other. So our team at Fuse Project, along with Cionic, which is a medical device company, and some engineers from Accenture, we were all recently shortlisted together as one of the 7 finalists in the competition to move on to the final round, which is very exciting news. So we're currently in that phase now. We're planning to deliver a fully functioning prototype close to the end of June. So that's what we have to look forward to. Naomi, why don't you kick us off and just tell us a little bit about the project, give us some background, and just set us up for our talk today.
Yeah, I think it's helpful to think back to end of March. The coronavirus pandemic was just starting to be treated as a real pandemic in the United States. A number of major cities, but not all, had issued shelter-in-place orders. We were seeing a fast rise in coronavirus cases, and that's in the United States. And at the same time, we witnessed what had happened in places like Italy that didn't have healthcare capacity to support the patient volume. It was becoming clearly very quickly that New York City and Seattle in particular were ramping up the dangerous peaks, and a big part of that was an expectation that healthcare capacity was not sufficient. Ventilators were particularly concerned. The supply chains were tied up by trade freeze, and there wasn't even really an accurate understanding of how many ventilators there were in the United States. But soon there were stories of ventilators being split between patients, and particularly besides care setting in New York, which is really an act of desperation given patient require settings that are specific to their size, their lung compliance, their oxygen levels. So the medical community issued that what can be described as the call to action to design and engineering community to help develop new, quickly deployable ventilator for coronavirus and ARDS patients.
Thank you, Naomi. MC, can you tell us a little bit about the approach that was developed for this project and how it was different from maybe some of the other projects that we do at Fuse Project?
Yeah, I think first to highlight something that Naomi was speaking about was that a key part of this challenge was getting something deployed quickly to market. So there was this speed element, but I would say like every Fuse project, we took it back to this kind of user-centered focus. So we have a fundamental belief that I think many designers do, that you can't have innovation without adoption. And so we knew that whatever solution we designed needed to be grounded in real human insights for people who are working on the ground in these healthcare contexts. So again, not very unusual for us, but I would say in the competition, that really set us apart. There were others that were taking really pure engineering approaches, and getting engineering right is of course very important. But again, our philosophy is really understanding the user and starting with that user mindset, those user needs, and designing for that context. I think another thing that made this approaching this challenge challenging was that the research context was really difficult. So if you can imagine, I think Naomi already had us like go back to April or March, but if you can imagine that time, there was really every day the healthcare context was changing, and what we knew about this disease was changing. And so we had a really kind of unstable setting that we were trying to design within. The other thing is that when we do research, we try to do best practices of triangulation of research. So that's a mixture of observation. So we want to actually be in these settings and observe human behavior. We want to do user research and actually hear from the users themselves what those needs are, and understand kind of their flows, their behaviors as they report them themselves. And then we also want to have quant data, and that's the triangulation part. It's those three things. But as you can imagine, observation's not possible in the middle of a pandemic. You can't go to a hospital and sit in a wing and watch what's happening. And similarly, as you can imagine, every person who we might want to speak to who was a user was probably in the busiest moment of their professional career. So, you know, it was a question of making sure that we could get enough of those user insights and really respecting the time of the healthcare workers that we were reaching out to lend us their insights. I guess, oh yeah, there's one other thing that I wanted to touch on, which was collaboration. And I think Harriet already spoke to this a little bit, but Fuse Project is a very hands-on design studio. So for every project, we set up more or less like a war room where we have things pinned up all over the walls. Our collaboration is really built around in-person ideation, in-person sketching, iterative prototyping, using our soft and hard shops. And so what's really challenging when you enter a shelter-in-place scenario is how do you translate that really incredibly rich collaborative process to a virtual format? And I'm not sure all designers at Fuse feel this way. I don't want to speak for everyone, but I think Fuse has set up some really interesting tools, like we're leveraging Miro pretty heavily as a way to really quickly get into those virtual collaboration spaces that we need. And I'd also say there's like kind of a silver lining to having less in-person time. Like we really want to use our calls much more efficiently, and that means everyone has, in my experience, we're getting more time to be heads down and really explore these problems and do the research on our own.
Yeah, and I think part of also doing research on our own too is like, it can be very, very overwhelming. So one of the key things that we asked in the beginning is like, how does a ventilator work? And that's like a big, big question that we've always asked ourselves constantly throughout the process. And so I think it's really important to kind of have individual research, but also be able to bring it back together as a group and teach each other every day, so that we can kind of learn from each other and kind of fill in all the pieces of the puzzle. And with that said, it's also about like interdisciplinary collaboration. And so with so many unknowns and time constraints, I think it kind of like forced us to kind of like all work together. And so it's interesting because like designers and strategists in this situation, we all have to kind of participate in different areas of research, and kind of our insights from, for example, a user interview with a health worker can actually have direct implications on mechanical engineering and interface. And so it's really important for us to kind of have that dialogue constantly every day. And if you can, I think we're going to show our kind of Miro slide soon. And basically, it's kind of like a collaborative platform where everything happens. If MC, you want to share. Yeah. And so, yeah, let's go through that. Yeah, so this is kind of like a quick glimpse of what our Miro board looks like. And basically, this board is everybody has access to it, from our engineering partners to me and the rest of the team. We're constantly kind of looking through and putting our insights on this big board. And so let's see.
I think what's kind of funny is that it kind of looks like chaos, but there's like
Yeah.
it's organized chaos.
Yeah.
I know flipping through it quickly, it may not look like it, but we learned how to make it work for us.
And what's really fun about Miro, as someone who doesn't use it on a day-to-day basis, you know, and this was my introduction to it, when everyone's on the same Miro board, you see everyone's arrows with their names on it, and you can kind of follow the crowd where everyone's looking and move around the board. So there is a way to kind of centralize the chaos.
Yeah, and we've also been able to kind of share our kind of designs through Miro as well. So if we talk to an RT, a respiratory therapist, they'll be able to see what we're talking about, and we kind of can collaborate together in the same platform. And I would say that as part of our integrated approach, this challenge, I think we were kind of embedded in all the user research from day one. So absorbing, synthesizing, and kind of challenging ourselves constantly about what we know with the healthcare professional. And obviously we also broke up into smaller groups to kind of tackle more specific questions. For example, I mean, me and another coworker, we would be on the same team kind of working on, you know, what does the spike in the flowchart mean? And that's like it, we stayed up till 5 just working on that question. And so it was really important for us to also go back to the RTs and kind of ask them and validate what we know with them constantly. So this kind of more iterative process is very, very unique to this challenge. And so we're also very grateful for all the respiratory therapists and ICU nurses that can give us their valuable time to kind of answer our questions.
Another thing I might add to that approach is that given this was competition, we didn't have a client to partner with. So it was sort of every organization for themselves, free for all kind of thing. So we had to really lean on our personal networks of respiratory therapies, ICU nurses, and ICU physicians to first really understand the problem. And then we return back to them and constantly show developments of the work and refine it as we went.
Harry, I think you're on mute.
Sorry.
No problem.
Still learning how to use Zoom after all these months. Just kidding. Naomi, can you tell us a little bit about some of those challenges that you guys ran into? What were some of those hurdles, and how did you and the team address them?
I mean, well, just like Judy and MC mentioned, none of us have worked with medical devices before. We were lucky to have partnership up to incredible engineering partners early on. Team members from Accenture Industry, X.0 Studio, who focus on mechanical engineering, and Cionic, who led the electronical engineering. We don't often work with engineering from day one, but that's what this challenge required: deep partnership, integration, and daily iteration. But back to the challenge, it's one thing to design a smartwatch for kids and quite another to design a ventilator. So these are complex machines with lots of stakes that creates both a sense of urgency and a commitment to accuracy and detail.
Right. And I think building off of what Naomi said, what's different with this is also like the medical context itself is very, very challenging. So I would say that the medical industry is kind of filled with a lot of proprietary solutions. And that's what we see in hospitals today. And the thing is, like, there isn't much kind of an open innovation within this field, meaning an innovation of culture, kind of the sharing of information, and it's a little bit more siloed. And I would say with one ventilator, once you purchase that, you're kind of like in this closed loop where you would have proprietary software and proprietary other kinds of accessories that would kind of go on the ventilator. So people are kind of like locked into complete solutions. And then on the other hand, we also saw kind of a rise in a lot of different kind of DIY solutions. And I think that it was really helpful because it was a great inspiration for us, but we can also kind of build on that. And so we learned from expert interviews, for example, we needed certain capabilities such as diagnostic features. And so those are really important. And part of the challenge was also to learn from what works and what doesn't, and how we can integrate that into our solution.
Can you guys share some of the highlights that kind of came out of that research, just some insight from that?
I mean, what Judy was saying with that kind of silo proprietary approach to care delivery also meant that as we learn in interviews, like every hospital had a different way of doing things. And this meant that, that we needed to have a certain degree of customizability so that our ventilator solution can be adapted to the workflows of different hospitals. This is largely a UX challenge, so it took a lot of interviewing and testing with host workers to understand the unique workflows of different hospitals, where they work, and design for kind of customizability and or flexibility that doesn't add complexity to a user experience.
Right. And one other kind of pretty important insight was that it's kind of like, for us, it was very insightful because we don't really have a huge, not all of us have a medical degree, but one important thing was that we actually learned throughout the process, like what makes a good and effective ventilator. And so, for example, for patients who experience ARDS, which is acute respiratory distress syndrome, there are actually a lot of potential negative impacts that can come from ventilation itself. And so in the best case, ventilators are supposed to support breathing to give the patients time to heal with their own body. And then towards the end, the patient cannot, you don't really have to rely on the ventilator so much anymore. It's more about the patient triggering their own breath. And so in the worst case, the human lung on a ventilator can actually be kind of weak and more susceptible to damage from overextension. So for example, if you have too much pressure, it can cause barotrauma. If there's too much volume, it can cause volume trauma. So on top of that, during the recovery phase, it's also really important for the lungs to have a constant airflow. So that's how we kind of came up with the idea of using a more pneumatic solution, meaning the solution has a lot more precision, and it can also have monitoring and sensoring capabilities versus kind of other kind of mechanical solutions. And so it was really important for us to also have diagnostic capabilities. So we know that we needed a screen versus not having a screen. So it was very helpful to it was really important for us to like inform RTs about what's happening to the patient, and so that they can make the right decisions to kind of change the settings on the patient. And another thing that's really important is that we kind of learned that there are some solutions out there that uses a different kind of ventilation. For example, I don't know if you've seen, but some of them have like a masks. So you can put on a mask and you can ventilate that way. And so one of the important things that we've talked to with kind of that's validated with expert research is that kind of CPAP machine can actually aerolize the virus. So with an infectious disease like this, you don't want particles to be kind of exposed to everybody. So intubation or this kind of ventilation is actually a more contained system. So it's really important for us to think about how to limit exposure and also the total viral load throughout this process.
I'd like to add a couple other insights that we uncovered along the way. I mentioned earlier that we weren't able to do observation, but one of the things I think really came in handy is just YouTube and user-generated content. And I think there was a couple weeks where I was just like addicted to YouTube and seeing like every video every nurse or physician was posting onto YouTube about their experience with coronavirus. And so, yeah, it was a dark period of my life. But basically, one of the things I observed in one of these videos was that particularly in these like peak scenarios of coronavirus, nurses were taking it upon themselves to create safety barriers for themselves. So what they were doing, for example, was I had seen that they were extending the lines of IV drips from the patient out into the hallway. And so that would mean that they didn't have to don all the PPE. So it's like saving both the PPE, but it's also, again, reducing their viral load. And so I was curious if that was happening with ventilation, and what I really couldn't find it. And then very like briefly in this like 2-second story within a New York Times, the daily episode, they mention, oh, don't trip over those cords. So it's like a 24 hours in the life of a Brooklyn hospital. And they're like, don't trip over those cords. Like that's the life-saving ventilation. And basically what they had done is what these nurses and physicians had done was break apart a ventilator so that it could be controlled from outside the room, or at least monitored from outside the room, so that they wouldn't have to always be exposing themselves to this incredibly contagious disease. And so what was really exciting about that, well, that's this idea that we have in innovation called lead user innovation, that I think is a really interesting wealth of opportunities. So it's when you look at users that have needs that are more extreme or like have not been seen by most users, and they're solving for those needs themselves. And those become really interesting scalable solutions. And then the healthcare sector, that this ventilation, breaking apart the ventilator, was a solution so that they could have more visibility into the room, and more the ability to monitor without exposing themselves to the disease. So one of the things we did was make sure that we were using, for example, sound signatures in alarms. Alarms have different levels of severity. Some are life-threatening, some are more inconvenient for nurses. And so it's having different sound signatures that indicate different levels of severity and when you need to go into the room and when you don't need to. We also want to make sure that there's visibility from outside the room, that they can kind of monitor some of those key numbers from the hallway. And then something we're exploring is, could you actually even have like a way of monitoring that data, like some kind of screen where you're monitoring that data outside the room? So that's something we're still looking into. And I think it's important to note this is still a work in progress. But yeah, it's that was a really exciting insight for me that was also validated, I should say. We didn't, not necessarily triangulated, but validated it through interviews with nurses who are experiencing a peak COVID setting. The other thing is, like in the innovation world, it's called an unlock. And I think when we're talking about real speed to market, in terms of manufacturing, we're looking for all the shortcuts of like really stripping down whatever's not necessary in the design. And so it also means for us, it was like looking to the context to see if there are ways to leverage the actual room, the context, the healthcare setting as part of the design. We were lucky to have environmental designer, Jayati, I don't know if she's on here, to join us. So somebody who could really look at that environment. But one of the interesting examples of this early on was Dyson's ventilator. So they had a ventilator design that essentially had these hooks for clamping onto the side rail of a bed. But when we showed that to nurses, RTs, physicians, something that we heard, especially from nurses, was that I spend all day like collapsing and resetting the rails. Having a really critical device that hooks onto the rail is actually like not only inconvenient, it's kind of dangerous. And so that pretty much wiped that solution off the table. But when we looked around, we're like, oh, something that's really unique and interesting is that what we were hearing and seeing in the data is that something like 70 to 80% of hospitals were actually, capacity was down to like 20%. So what I mean by that is 70 to 80% of the rooms were not being used because of shelter-in-place practices and quarantining, which were reducing trauma incidences, and also all elective surgeries were canceled. And so that meant that there's a lot of equipment that's sitting around being unused. The most basic of which is almost like a commodity in some ways in a well-resourced healthcare setting, is an IV pole. And so what we did was we used this IV pole as a replacement for building in a stand or some kind of support structure for the device. And actually it has all these great positive benefits as well, unintentional kind of benefits, which is that when you have a device that's really small and you can detach it, what you've also solved for is storage problems. So there's a lot of storage problems with these ventilators, so you made it really easy for these things to be stacked on shelves. And then also IV poles are portable. So what we've done is take a traditional ventilator and turn it as well into a portable ventilator, which is actually usually a different kind of device that's used in healthcare context when transporting a patient to, say, a CT scan down the hall. And so we've made it portable, we've made it easy to store, and we've also made it in like a user kind of experience. From a user experience perspective, we made it really adaptable, so nurses can make sure that they can see it they can adjust the height of the device on the pole so that it's legible from where they were from the hallway. So we've addressed that kind of like reducing viral load, increasing visibility, and also adjust it to a position that works for them. So there's all these kind of benefits of using unintended / let's just call them intended benefits of using the IV pole. Yeah.
Yeah, and I would say also one of the key insights is also from the actual technical constraints of the actual project itself. So part of the technical parameters of the challenge is that it needed to be rapidly manufacturable. And we wanted to leverage kind of 3D printing, which is one of the partners of the challenge as well. And so there's really interesting things that new capabilities that 3D printing can offer. For example, how do we, the first question is like, how do we simplify assembly and manufacturing? And so with 3D printing, you could have multiple materials, colors, and even kind of components integrated into the housing itself. So for example, we were able to kind of create a gasket just kind of in one go from one manufacturing process. And so another interesting thing is also like thinking a little bit about kind of the overall kind of aesthetic. With this project in particular, I think that the overall aesthetics is really kind of driven by the function. And so, for example, you will see in our design later that on the surface, there's actually a metal kind of surface, and it has one single bend. And not only is it very kind of a really simple design, it also allows the surface to be easily kind of sanitized and wiped down. And it's only like a one single manufacturing process. And so I would say with this particular project, I think aesthetics it's really interesting because it's kind of trying to inspire more of a confidence and stability to our users. And also kind of the focus is on simplicity and legibility and kind of the most easiest kind of adoption process, so that the whole kind of experience is seamless for our healthcare professionals.
Great. Do you guys want to pull up the design and kind of show everyone what we're talking about?
Yes. Awesome. Hey.
Okay, here we are. Introducing Vox. Can I get yays or nays on the name? We're still testing it.
Yay.
Yay. It's a pneumatically driven ventilator optimized for a COVID-19 healthcare context and assembled in under 4 hours. Yeah, so this is, some of this is going to be essentially a summary of what you've already heard, but it was really important in our process to look to the context for these innovation clues. So that was around really leveraging what the space and the behaviors to understand how to make a really critical innovative design. We also, yeah, was someone going to say something?
Yeah, I guess I want to talk a little bit about kind of the mechanism inside. So we kind of wanted to rely on a more, a safer kind of delivery of ventilation. And so we wanted to use kind of the existing pressurized air system in hospitals instead of a more mechanical kind of approach. And so that was what kind of inside you see all these kind of, all of the components are kind of 3D printed, and some of the components are actually kind of fixtured. And so this actually allowed quality to be controlled if this was kind of quickly and rapidly manufactured.
Do you want to speak to this one too, Judy?
Yeah, and so I think here you can see that there is, this is kind of like the shell and the housing. And so there are, you can kind of, what we did was there was kind of like a gasket that's like going to be a little bit softer, and then it is a multi-material and multicolored. So like, for example, some of the components that need to be color coded can be actually 3D printed right away. And so it also allows the tank, mixing tank, a venting and other fasteners to be kind of printed and kind of fixed onto the shell.
Yeah, really improving the assembly process.
Mm-hmm.
How about Naomi for this one?
Yeah, so when we think about the interaction with the ventilator, we really wanted to make sure that we're not introducing the new way of interacting with the ventilator using what's existing in the market. Therefore, we choose the rotary dial for the menu. So very simple. That's how you can confirm and move to menu. And also the two physical buttons on the left is for the oxygen boost and silent the alarms. So we really wanted to make sure that the interaction elements is very also still attached to the screen, so that therefore, like when you're looking at the screen and controlling it, you know that which one you're looking at. And really, like even with the visually, we wanted to separate the elements that's interactable and that's aesthetic.
Mm-hmm.
So that's Vox, and we just really want to say thanks to, these are just some of the medical experts that we spoke to. And again, like this wouldn't have been possible without their insights and feedback along the way. And also a thank you to all of the frontline workers who have made sure the country stayed moving in the wake of this crisis. And lastly, a little credit to the whole team, because you have 3 of us here speaking today, but it was as you can see, a significant effort by the Fuse Project team. There was a lot of people eager to participate and give their time. Oops, some loud noises going by. But some keenness, some energy, and a lot of momentum from the Fuse side to work on this challenge. And of course, our 2 partners, Cionic and Accenture.
Thank you guys. That was awesome.
Yeah, thank you guys. It was so interesting hearing, how you go through your process, and especially during this time working on something that's so important. And best of luck with the competition. Does anyone have any questions? You can either digitally raise your hand or you can put it in the chat box. Harriet, do you have anything that you want to ask them, or? I guess no one has questions today. Oh, there we go. Someone is asking, Aaron's asking, how much does it cost?
So currently, I would say that we're still kind of reviewing all of our components, but I would say that our cost is definitely, we're trying to kind of target it towards under, I would say, $1,000. And that is with kind of most of the components, and part of the main components, for example, the venturi tubes, they're going to be all 3D printed. And for example, the buttons are going to be all from 3D printed material because the icons itself can be a different color. And so we can actually leverage the same manufacturing method to produce majority of the parts. So yeah.
And you said that it can be assembled in under 4 hours?
Yes, that is kind of our goal. And based on kind of all the components, I would say, yeah, that is our goal.
Hey, does anyone else have any other questions? How do you get up into a partnership with the other teams that you're working with?
I mean,
Yeah.
I was going to say Harriet might know a little bit more about that background, but my understanding is that these were relationships on past projects. So we were able to really dig through past partnerships on client projects and kind of recruit the teams that we've worked the best with in the past, which is a privilege to be like, hey, we really love working with you. Will you come back and work with us on this project? And I think what's exciting is, well, first of all, we heard that a number of engineers were already working on this challenge. So it was amazing to hear how many studios were also working on ventilators or other really critical devices for the healthcare community. But then it was just really easy to recruit because people are excited to also work on this challenge with us. Harriet?
Yeah, Honestly a little bit of an effort at the beginning just to find the right people. You know, we approached it the same way that we would approach putting together a vetted team on any effort, right? It's about finding the right chemistry, having the same sort of values and perspectives as us and what we want to achieve. And this was kind of an interesting one because a medical device is actually much more of an engineering lift than it is a design lift. So making sure that we had the right leadership on the team was also very important. And of course, this was all done during shelter in place. So it was all through Zoom calls and phone tag and trying to track someone down via email before we found the right team. But we're very excited to be working with Cionic, whose CEO is Jeremiah Robeson. He used to be with Jawbone. So they sort of led the medical device part of the project, and we have some folks from Accenture who are donating their time to work with us on it as well.
It's amazing they've been able to pull everybody together, and as you were saying, you're all doing this virtually.
Yeah.
But being able to work really effectively together.
Yeah, some of us are at home, some of us are at our parents' house, right? And we're all over the place, and not once, I think, has anyone really been together yet. But we're getting to that point, I think, where it's time to maybe powwow in someone's parents' cul-de-sac or something.
Yeah, but it's just really impressive that you did this all together without actually being in front of each other. So congratulations. Are there any more questions? And if not, we can probably wrap up. All right, well, thank you again, everybody. Harriet, Nick, it's always amazing doing these with you, and hopefully we'll do another one soon. Everyone have a good rest of the day, and we will, oh wait, hold on. Dustin, do you have a question? There we go. All right, his question is, with the physical product, how did you collaborate online when dealing with the remote constraints?
Right. I would say that I think we still kind of found ways to kind of figure out, for example, scale. Yes, exactly. Interaction size, etc. Yeah. So for from ID point of view, I think that we still kind of found really interesting kind of references as to for example, what is the size of an IV pole, and then we kind of did a lot of our own kind of scaling. For example, okay, what is the right height, and that we kind of have to imagine a little bit. But there are always really good references from kind of online, and also kind of ordering. I know our kind of ID leader had he would order an IV pole, even though it shipped a little bit later, but it was still a good reference. And so we could still kind of be creative and think about how we can kind of still prototype within our own means. And then obviously, for example, our electric engineer, he would make small prototypes that would still kind of inform us what's happening. And even though I think he did it in his own kitchen, it's still very informative and the results are still very accurate. And so I think that we can find interesting ways around these kind of more physical challenges.
Yeah, I think Daniel's actually on the line.
Oh, Daniel. Yes.
But also, I mean, some of our designers have home 3D printers. So there was also, we were still kind of doing that, yes, those kinds of iterative cycles of printing and testing. And there's, like you said, a lot of videos in people's kitchens and testing out works like prototypes. So yeah.
Yeah. Oh, another thing is also with, for example, with Naomi, we want to talk about a little bit about the user interface and how we kind of collaborated with doctors on that.
Yeah, what we've been doing, because we can't be we don't have the physical prototype in front of us. What we did was we built the prototype, and then we'll run them through and then tell them is this mode, this is how you will interact with this ventilator. Does this make sense? And we'll do user research, but while using that prototypes, and then make sure that this makes sense, and then we're doing the right things too.
Mm-hmm. Yeah, and so even with the two-dimensional kind of interface, you could say a lot about the functionality behind it, and so that was really, really important for kind of all disciplines. Mm-hmm.
Great. Thank you all. Or I'll let Simran take that.
Yeah. Thank you everybody. Thank you to our audience, thank you to our speakers. This is going to be going on, it's already on Facebook right now, and it'll be going to a YouTube channel. Our channel name is Canopy Events. So yeah, I will see you guys soon, hopefully.
Awesome.
Bye.
Thank you, everyone.
Thank you. Bye, Simran.
Thank you.
Thank you.
Thanks, everyone.